Well, thank you again, everybody, and welcome to our Ethos webinar this evening, hosted by Dr. Nick Kulkarni and myself. He is presenting on the predictable results with Ethos synthetic bone grafting, a review of the best practices to help ensure graft success with minimal failure. So thank you to Nick for his time this evening. A few housekeeping things this evening. A little bit about Ethos, the upcoming events. You would have seen Ethos at many events this year. And the next upcoming events are next year. So we've got ANZIP in March. We've got another webinar in February, and then we've got our AOS events throughout the year. Questions are encouraged in all of our webinars. We will do a live Q&A at the end with Nick, so please pop your questions into the question box down the bottom, and we will do our very best to answer as many of them as we can. If we don't get around to answering all of the questions this evening, we will get all of the questions answered by Nick, and they will be emailed out to you. So please make sure you pop all of your questions in. Your CPD certificates will be with you in your emails within the next 5 days, along with the recording. When you do finish tonight, a super quick survey will come to you. Please take the time to fill that in because your feedback is so important to us. And on that survey, there will be a tick box to add yourself to our Ethos newsletter. So please do that. That will keep you up to date with everything Ethos. It will tell you where we are, what we're doing, and what we've done. So I won't hold you up anymore, but please, thank you, Nick Kulkarni, and we will hand over to you for your webinar this evening. Thank you.
Hi, Ash, can you hear me?
Yes, loud and clear. Perfect.
And you can see my screen?
I can indeed.
Perfect. Okay. Thank you, everyone, for joining. I know it's a weekday. It's the middle of the week. Everyone's busy. I appreciate the time everyone's taken out to hear this presentation. I will do my best to keep it concise, and I'll try my best to answer all the questions that you may have at the end of it. This is a bit about me. We've got a practice in Leichhardt. It's a small practice. We focus mainly on general dentistry, but with a bit of emphasis on dental implants. I did my grad dip from Sydney Uni, but I've been doing implants before that. I formalized the training with Sydney Uni, and I completely enjoyed the course at that time. I started using Ethos pretty much since it was launched in Australia, but I had used a type of beta-tricalcium phosphate back in 2006, and I actually got good results with it. But then for some reason it got discontinued, and we didn't have a strong company to support it. So I started using xenografts, allografts, and all sorts of things during that time. And when Ethos got launched in Australia, I was one of the first ones, I think, to start it. I was following Peter Fabian's work online, and it sort of made sense to me to start using it here. Ethos is sort of now my go-to material. One of the biggest reasons I feel I got attracted to Ethos is because you don't have to have a long conversation with patients about what is the material. When the material is synthetic, I found in private practice, the uptake of grafting is much better, much easier. There's no religious aspect to the kind of material we're using. Cross-contamination is well, none, and so that's from a patient point of view. Also, there's beautiful turnover rate of the graft, 50% at 8 weeks, and that's been documented. Peter Faber talks about true host regeneration, and you can actually see that happening. No need for membranes. That's a big plus for me. So the armamentarium that you need to stock in your practice is less. You no longer have to worry about, is the membrane too short, too small? Do you have to wet it before? So the procedure becomes a lot simpler. Because ethos sets hard, we get a very nice substrate for the tissue to follow. And I've seen that tissue's response to ethos is actually quite nice because of the hard base that ethos gives it. It's relatively easy to use, but you need to get a hang of it. So it takes time to relearn some of the techniques that we are used to. I've got some videos at the end to actually show you what I do. Ash is always there to support. So Arc Health support, I mean, any company, any product we use needs to have good support, and they are always here to help you. It's also cost effective. Although Ash, it could be a bit cheaper. I would love it. But that's how we all want it. Okay. So ethos is essentially calcium phosphate with calcium sulfate. The calcium phosphate helps in absorption of the protein matrix on the surface of the graft. It sort of starts the cellular signaling mechanism to induce bone regeneration. And calcium sulfate part also increases the osteoblastic production and reduces osteoclastic activity. And that's essentially how the chemistry of ethos works. Now, we talk about how much of the graft is preserved after any regeneration process, and that's quite important. Based on this literature review, 50% of new bone formation was seen in ethos as compared to, I mean, the amount of residual graft material left is much lower in this. Okay, let's jump into cases. Let's not talk too much about the chemistry because it's a weekend, it's a middle of the week, and you don't want to dive in too much into literature stuff. But there are papers available, and I can send you links for the scientific material that I've read, and we can always provide you with all the information you need. So let's start with this lower anterior case with significant defect. This is how the patient presented. Missing 3141 to trauma. Extractions were done by the referring dentist, but I suppose there wasn't much degranulation done at the time of extraction. So there was a pretty significant granuloma after the soft tissue had healed. So the plan was to raise a flap, clean out the lesion, place an implant in the basal bone, which is nicely compacted and nicely healed. So we're hoping to get a good, or rather sufficient torque with good primary stability to then be able to do an immediate in this case. This is the full thickness flap. That's the site curated. That's all this granulation tissue that came out of the site. Implant in correct 3D position. We got a full torque of 35 Newton centimeters on this, and that's why I could place a healing abutment straight on the day of implant placement. That's grafting. So some of the things that we need for ethos, and it's quite critical actually, is a dry surgical field. Reflect the periosteum before mixing the ethos. The mixing has to be correct. Do not overgraft the area. When I first started using ethos, I thought more is better, but it's actually not. You just need the right amount to give you a good amount of contour. And that's the closure at the time of surgery. Then we waited for it to heal. 12 weeks later, we see good amount of soft tissue coverage. It's holding the buccal keratinized tissue really well. And we were actually ready for an impression to start loading it. And that's the case finished. So single implant to support 2 crowns. So ease of hygiene in the region. Rather than placing 2 implants for 2 teeth, it was better to place 1 implant so you can so the patient can have good access to hygiene. Then this is a CBCT post-op. I think it's been about a couple of years since this case was done. I do not routinely take CBCTs to check for how the graft is going. This patient also needed implants in the second quadrant. So I happened to take a CBCT for him in the second quadrant, and I was keen to see how this ethos is performing. So we see good amount of bone adaptation on the buccal in this slide. Oops. Second case, again, a lower anterior. This is the pre-op presentation. Periodontal issues. So we did work on the periodontium quite a bit. There was significant hygiene advice. And before we started with the implant part, we worked on the perio. That's the extraction done. We have significant granulation tissue over here. Yeah, that was completely cleaned out, and we can see that we've reached good, healthy bone at the base of the socket. And that's the implant at correct 3D positioning, good insertion torque. But I did decide to bury this implant purely because I still wanted to monitor the periodontal maintenance of this patient. So ethos was grafted on top of the exposed threads, and then we closed it. This is that re-entry. So we see good tissue healing. Not a whole lot of keratinized tissue, but I can live with that much. We can probably split the keratinized tissue, a bit on the buccal, bit on the lingual, and make it work. Flap raised to check for how much bone regeneration we've achieved. And we've got a couple of threads exposed, but given the fact that there were about 8 or 9 threads of the implant exposed, we got pretty good regeneration. In hindsight, today, I would have probably added a little bit more ethos, but I decided to go ahead without adding, or without rather doing more additional grafting at this time. And that's the healing abutment placed after stage 2. And on the left-hand side, we see the final crown, screw retained prosthesis, and that's the final result. So the patient has definitely taken up hygiene quite seriously after this episode. His general periodontal condition is quite all right. It was only in this region that he had advanced periodontitis and he lost his tooth. And this was a bit of a awakening for him to step up his hygiene. So periodontially, the patient is stable, so we could go ahead with the implant placement, and that's the result. Timing of implant placement. Now, of course, we have immediate implants, early implant placement, delayed implant, and late placement. In the literature, I've seen that immediate implant placement is equally successful as early implant placement. When I first started using ethos, I would, as a general rule, do the extraction, wait for it to heal. So I would do an early implant placement most of the times. But as I got slightly more experienced, because we are always constantly in practice, I started taking a few more risks, for a lack of a better word, and started doing more and more immediate placements. But coming back to this slide, I think early implant placement, 8 weeks post-op, is probably a very comfortable time for implant placement. You have soft tissue closure or soft tissue healing at that stage. So grafting becomes a lot simpler. There is no bone healing, of course, but bone healing will happen in later stages. But when you have a good amount of soft tissue, it's a much easier situation to manage clinically. Delayed versus immediate. So this is the literature review from this is the conclusion of the literature reviews. Survival rates for type 1 and type 2 are the same. Of course, type 1 immediate implants do require a fair bit of clinical assessment and a bit of skill on the type and experience on the part of the surgeon to do it predictably. So does immediate implant placement prevent residual ridge resorption? No. I mean, ridge resorption is actually a genetic process that's going to happen no matter what you do. Whether you do immediate grafting, you can minimize it and maintain it with immediate grafting, but resorption of the ridge is a genetic process, and that's going to go on no matter what. So we talk about key steps in implant planning, prognosis of the tooth. I think the best implant that anyone can actually do is the original tooth. I always tell my patients, I said, the dentists in the future will probably not be doing these implants. They'll probably place some cells and grow you a new tooth, but it's probably not going to happen in our lifetime. Planning of the extraction is very critical. If the tooth has to go, it needs to go as soon as possible. Strategic value of the tooth. I don't necessarily do 7 implants if they don't really need to. Socket grafting, whether you should socket graft or not, I'm slightly more in favor of 8 weeks and then implant placement rather than socket grafting. If I was to socket graft, I would do it for a patient who is undecided about getting an implant or not. So in which case, to maintain tissues, we would do a socket graft and then they can think about it later. Loading protocol, periodontal considerations, anatomical considerations, occlusions. These are all very important steps, and all of us who do implants are well aware of all of these things. Ridge preservation techniques. Now, bit of dive into the socket grafting side of things. It does maintain the ridge volume. Amount of bone or new bone formation in the socket was actually quite so varied that you can't really make any clear statistics on it. 20% to 60%. It's a huge number. Lack of support to lack of evidence to support any superiority of technique. That means if you have whether you reflect the whole periosteum and close the socket graft, or you leave it open to allow for secondary intention healing, it's sort of been inconclusive. But my practice is, if I was to do a socket graft, I prefer to almost close it not leave it really open to the oral environment. Ideal implant placement. The reason I'm going through some of these slides is because there are no miracles that can be performed. All these basic scientific principles that we've been taught at uni for how the implant should be placed are actually very critical than ethos or any material that we use. So the reason for these slides was to actually harp on the fact that going back to basic science and doing your treatment planning accurately is actually the hallmark of good implant dentistry. Incision designs, it's very critical, because when we are grafting, that is what is going to make it or break it in a way. You have to be mindful of the anatomy. So lower 5s, you've got to be careful when you're reflecting your incision. Upper 7s, you've got to be a little careful because of the arterial anastomosis in just above the upper 7 region. Tension-free closure is a very important part of closure, because if there's tension in the flap, we do end up flap opening, and flap opening can cause you need to then, if your flap opens, then you need to rely on luck for healing, and I don't think luck is a good way to go around with grafting, especially. Okay, so learning from failures. That's the pre-op case where the patient needed implants in the second quadrant. Looked like a pretty decent case. It wasn't really something very difficult. There was thin bone. The extractions were done a while ago, but there's a good amount of keratinized tissue. So it felt like it was a good case to do. Healed side, so I thought everything is going to go well. This is how we placed the implants. Apologies for the photo. 2 implants in place, buccal area grafted with ethos, and then we closed the, sorry, come back to this. We closed the flap, and I thought I did quite well, but this is what happened in 4 weeks' time. Now on this slide, it looks like the angle of the implant may have been too buccal, but that's not really how it was. I suppose the patient was wearing a denture, and the flange may have opened up the incision, and that's probably why we had a failure. So back to the drawing board. took both the implants out, regrafted, changed the vertical releasing, went a bit more distal to the premolar, and then finally we got good success at the end of it. And that's the final prosthesis, screw retain implant supported bridge in monolithic zirconia, and I think the patient was happy. As luck would have it, he was a very nervous patient and quite phobic about dentistry. And when I did the surgery for the first time, I was hoping if I was to have a failure, I do not want it in this patient, but no, I had to work twice as hard, get him on board, have a long conversation about failures, but what do you do? Such is life. This is a case that I've done 4 years ago. This is a comparison between xenograft and ethos. We'll have a look at the case, and then I'll make some comments about the same. So, history of failed endodontics. The teeth were deemed non-restorable. There were lesions around them. Endo had been done. There was root fracture. So the extraction was done by the referring dentist. And this is at the time of placement, significant buccal defect. So on the left-hand side, on the 2-1, I placed an implant with ethos. And on the 1-1, I placed a xenograft. And then we closed it. I was quite happy with I thought we were going to end up with a fair bit of vertical tissue loss, but I think we were lucky in that we didn't lose a lot of vertical tissue. So that's the healing before stage 2. Re-entry at 12 weeks. Now, on the right-hand side, we've got, on the 1-1, we've got a xenograft, and on the 2-1, we've got ethos. So you could argue that ethos is, and there's not a huge difference in clinical aspect of what we see, and that's the final result. So we had implants parallel to each other, splintered impressions, splintered crowns for the anteriors, and this is I think 4 years later. Now you can see in the 2-1 we've got ethos, where we see the soft tissue contour is nice and favorable, but where I've done xenograft, there's a little bit of a dip. I think with the amount of manipulation of the flap, possibly that could have been caused by that. And I just want to make a comment that this is just one case. It is not. This is my experience with it. For those who use xenograft, it's not like ethos is any significantly different in that sense. But I've found that this works. In this case, it really seemed to be looking good. Okay, another case, immediate extractions, immediate implant placement in the 2-1, and I think it was delayed 8 weeks placement for the 2-2 because the referring dentist had taken out the 2-2 at that time. Extraction was done in the 1-1, implants in position, good torque, jump space grafted with ethos. This was early days of ethos, so this is one of my earlier cases when it first came, and I think I was overgrafting at that time. So there was today I wouldn't put that much graft, but it still worked. This is at the stage 2 re-entry. We do see there's good amount of bone on the buccal of those implants. So impressions, splintered, and then splintered crowns. And I've been following up this case. It's been 3 years now. We don't have any tissue loss. The hygiene of the patient is reasonably good, and he's maintaining it very well. So let's go to the next case. This was actually a charity case. He's a courier delivery guy, and he had trauma a few years ago, and he came to me and asked me if I could help him out. So it was a bit of a charity case. Very interesting case in that the lesion was quite significant. So the 1112 had history of trauma, post and core, possible fractures, failure of endodontics, and a very large lesion. In this case, I decided to go with a delayed placement. So I took this, I did the extractions, and one of his mates made him a denture. Because he's a courier delivery guy, he goes to a lot of practices and places. So he got a denture made, and I said, well, we'll wait for 8 to 12 weeks before we go in and do the implants. At the time of extractions, I curated the lesion as well as I could. I really wanted to preserve the interradicular bone, so I didn't. My access to the site or to the lesion was a bit limited. This is a picture of the degranulation burrs that I have in my armamentarium. I would highly stand by them. They're really good at scraping out tissue tags, residual lesions from the bone without causing too much trauma. And this is at implant placement. Implants were placed in the degranulated site. We have buccal volume loss, so it was grafted with ethos. And this is the closure, and this is the PA at the time of placement. So at the apex of the implant, I had to place some amount of wet ethos. There's wet ethos and then there's dry ethos. So wet is quite a slow sort of slurry of ethos that goes inside, and you just leave it in there. Then you drive your implant in, and then the rest you graft with the standard dry mix of ethos. And this is after healing. I think he healed quite satisfactorily. I took an impression. I made some custom healing abutments for him in the hope of trying to gain some papilla in between implants. But the ridge was quite flat. So just made a little video about how, before placing ethos, I make sure that I've got enough flap mobility. So just make sure that you have tension-free closure before you start mixing ethos. This is the setting of ethos. I made this video just to demonstrate before you close the flap, this is how you really ideally want the ethos to have set. So it sets almost like dental stone. And that's the healing, 12 weeks, re-entry. We see sufficient bone volume on the buccal. I customized some healing abutments for this gentleman, but I always told him that with a ridge like this, to create papilla in between implants is going to be very tricky, if at all. That's the healing with the custom healing abutments, and that's at the time of impressions. Since it was a charity case, I decided to do the prosthesis part myself. So I took an impression, put implant analogs, poured up a soft tissue model, bought some prefabricated abutments, prepped them, and then scanned them with CEREC, and then drilled a hole at the back, bonded them on the model, on the abutments. So basically made a screw retain individual crowns myself, and that's the result. So we've got prefabricated abutments with Emax crowns, and now we are hoping and praying that the papilla would grow. His hygiene is not the best, although he says he's trying. So I'm not really sure whether the papilla is going to grow. But thankfully, luckily, his smile line doesn't really show it. So we're saved a bit in that regard. Okay, let's go to the next case. This was a trauma case, central incisor 1-1, buccal abscess. So planned to do an immediate implant. So we took it out. I'm sorry, this was a heel case actually. Implant insertion at the correct 3D positioning, papilla sparing incision, full thickness flap to reflect the periosteum to access the site for grafting, ethos placed and sutured. And this is the healing we see at 8 weeks. So I was quite satisfied with the healings. Now you can see that the buccal contour in a healthy patient with good hygiene is quite nice with ethos. So the amount of keratinized tissue is also quite adequate. And that's how we finished this case. Crown in 1-1, implant supported crown in 1-1. This is a 2-year follow-up. And we see the buccal contour is maintained quite well. Sorry, I just have a question. Ash, can you hear me? Can you see my cursor, Ash?
Yes.
Okay, cool. Thank you.
Yeah.
All right, let's move to the next case. Trauma case again, missing 2-1. And it was a very old trauma, and the patient was wearing orthodontic appliance for a very long time. He used to have a wire and acrylic tooth in between. Couldn't afford the implant for a long time, and then finally he came in to have this done. Significant tissue loss. Now here we can see that there is sufficient amount of bone, but that's not in the prosthetic position. That's going to be too palatal to where we actually want the implant to be. So as much as there is this good, healthy host bone, I can't really place the implant in that region from a prosthetic point of view. So the implant had to be placed a little bit more buccal in the right position. So we've got the papilla sparing incision, exposure of the mucoperiosteal flap. I've noticed that in long-term cases, there's a lot of soft tissue adhesions. So the periosteum doesn't reflect very cleanly. So you've got these tissue tags going into the bone. And if we were to do anything on top of that, we'll have epithelialized healing and not a real bone turnover of the grafting material. So the degranulation burrs, we use them again, and we degranulate the site, remove all the tissue tags. So you basically want the bone to be nice and clean. So on the left-hand side of the screen, we can see it's nice, clean bone now. Osteotomy was done. There wasn't much buccal wall, and we knew that the buccal wall is not going to be left. And that's the implant in place. Although I did get 35 newtons of insertion top, so primary stability was quite good. But we have no buccal wall, and the buccal threads are completely exposed. And so at that time, at that stage, we decided to do some ethos grafting over there. Concise graft, not overgrafted. Tried to manage the tissue really well without any perforations. Sutured up. This X-ray is taken at the time of implant placement. And then we come back 8 weeks, 12 weeks later for stage 2. And at stage 2, I see here on where the incision line was, there's a little inflammatory granuloma. And I've seen these on and off, and if they're not infected, it's not such a big deal. You do need to curate them, and it takes a bit of work to curate the lesion and take a little very tiny fine suture so that you don't have the flap exposure at the second time. But this is at re-entry. This photograph is at re-entry. So we went from almost all the threads exposed to now having the apical threads within bone. And now we still have this defect. So this part of the graft would have been resolved, but this part of the graft at the apex has done its job. When I'm doing cases like these, I always tell the patient that we might need multiple grafting. So in fact, with this case, with this patient, I told him that we might have to go in and basically just graft and leave it alone to heal. Whether I'll be able to place the implant or not, I'll have to check when we actually go in. So he was prepared for 3 grafting procedures, but we managed to finish it in 2. So this is grafting at stage 2 while you place the healing abutment. And then on the right-hand side, we see the heel side. This is at the time of impression. We still wanted to maintain the space, so the orthodontist still had the appliance on him, and the wire was being placed. So the blue blockouts are basically so that I can take an impression while the orthodontic appliance is still in place. Again, another view of the impression post. Here we can see that there's good cingulum access, so the implant is positioned in a prosthetically driven implant planning. And here we can compare the defect, which was quite a significant defect. And now we see there's good amount of soft tissue and hard tissue volume on the buccal to maintain long-term stability. That's another view. And that's the final. So we've got a screw retain restoration. And in this slide, I'd forgotten a little suture on the in the buccal, which I finally took out. But this is at the time of final delivery. So I think the patient's quite happy with what he's got. Another case. This was a patient who was short on time. They were moving. I don't really know what the personal situation was, but she didn't really have the time to wait for extractions, wait for it to heal, and then go and do the implant bridge. So, of course, in the informed consent, I said we will attempt to do the implants and everything, all the surgical side, almost in one go, but there are no guarantees. So if I'm not happy, then I might just have to close it and let nature take its course and heal and then come back. She was on board with it, so we decided to go ahead. So I sectioned the bridge. The plan was to section the bridge behind the tooth 3. The tooth 3 was actually quite okay. It had a post and core. We sectioned the bridge, removed these teeth. While sectioning the bridge, the tooth 3 crown actually came out. But that tooth is actually quite okay. So we're going to re-cement the crown later. 2 implants in place. The site was degranulated really well, reached host bone, reached clean bone, implants placed at good insertion torque. And of course, we have a pretty large jump space, which was then grafted with ethos. So we can see that all the infection was curated. Implant is in primary host bone. Here we've done a bit of indirect sinus lifting with some osteotomy, and the rest of the jump space was grafted with ethos. And that's the bone levels at the time of impression. Of course, splintered impressions, and that's the prosthesis for the final screw retain bridge. That's the soft tissue healing. Before I started the case, I told her that 2/7 needs to be extracted because it was a non-functioning 7. And I said, you don't really want a non-functioning supra-erupting 7 behind a new implant bridge to create a hygiene issue. So at the time of stage 2, we did the extraction of the 2/7. And that's the final prosthesis. Oops. Okay. So we've got the screw retain prosthesis over here. The sinus lift is looking good. We've got the host bone formation just above the implant in that region. This was a unique case in the sense that she had the rest of her dentition was her own dentition, except for quadrant 2 and quadrant 3. So here I'm looking at implant supported dentition versus implant supported dentition. So the lower implants, I had done the lower implants a few months before the upper. And this was the occlusal scheme was canine guided. We didn't want implant on implant occlusion to that extent. And with implant supported occlusion, the way we do it, she came back and complained that she can't eat rice. And then I had to sit down and explain to her that the rest of the dentition can close, but the implants, if I let you bite fine food with implants, you will actually put them in overload. So it was interesting. So I just thought it was a good learning curve for me to have this conversation in my consent if I'm doing implants against implants, that with natural dentition on the other side, that you have to have this chat before doing the implants about the occlusion. It's another case, immediate molar, uh, failed root canal, non-restorable tooth, uh, extraction done. Implant was placed in the furcation area. The jump space was grafted with ethos. We had a good insertion torque, so I could place the healing abutment on the same day. That's immediate post-op. And this is how the soft tissue looked before final crown insertion. So we got very good soft tissue profile before the insertion, and this is ethos still maturing. So usually at about 3 months or so, when you take an X-ray of the grafting, it doesn't look very radiopaque. It actually starts looking radiolucent at that stage, which is quite different from what normal X-rays we are used to. But as long as the soft tissue profile is good and there's no bleeding and suppuration from your soft tissue, you do not need to worry about the radiographic view of ethos. Wait for a little while. Now, this patient also, this is a 3 years post-op CBCT. Again, I don't do routine CBCTs. This patient needed implants in the second quadrant. So I ended up doing a CBCT and I couldn't wait to see what's happened over there. So we see good amount of bone apposition on the buccal and lingual, and that's another profile of ethos. So the graft is nicely matured. It's homogenized with the rest of the host bone. A few additional cases. These are in progress. I've not finished them, so maybe they'll be ready for the next webinar. But I just thought I'll show you how I mix ethos. So when you mix ethos with, because it's the calcium sulfate is the one that actually allows the setting mechanism. You don't want too much water. You just want the right amount of water to wet it. Because if you, and once you wet the ethos, you have a limited amount of time to work with it. Once the ethos is dried, you basically have to chuck it. You cannot really re-wet it and reuse it and keep it wet. So this is where there's a bit of learning curve with ethos until you get it. But Arc Health will provide you and can provide you with a lot of practice non-sterile ethos to get it right so that you don't have to waste material. But that's the video of the mixing. So I just make sure that I wetted it all the way. So I'll just stick an elevator in it. Just give it a bit of a mix. Squirt out the excess water. And that's it, you're ready to go. And this is the actual placement. So you bring the ethos in there, express it in the site. The site has to remain relatively blood-free and clean. So all your periosteal elevations and all, I prefer to do them before. And we just mold the ethos in shape. You dry it. Let's close a bit of it. That's that. Okay, and then this is how it should sit ideally. Okay, you close it. That's how it should sit. Nice and strong. And that's the future. So I've done the periosteal reflection. My flap is now under tension. There is a little bit of tension because of the reflection, but as such, the flap is not in tension. And that's the first suture to stabilize the flap there. That's let's just continue as an artist. So here you can see it's there is no tension in the flap. It's nice and stable. All right. Final take-home message. Ethos is not a miracle material. Correct surgical techniques are critical. Follow scientific principles, implant positioning, implant planning, all of those things lead to success or failure. Ethos is an adjunct for you to perform these procedures predictably. If you the videos that you saw were in real time, so the amount of time that you save in a surgical site is quite significant. Mixing of ethos takes about half a minute, and placing that was real time. I'd not edited those videos to make them fast track or anything. So 2 minutes, 3 minutes, 5 minutes of bone grafting, that does help a lot in keeping in how long your flap is open. So that's pretty much it from me. Thank you for your time. I hope I kept you all awake, and we still have 10 minutes to talk if there's any questions.
Fabulous. Thank you so much. They were fantastic cases, and you have so many wonderful things to show and teach. And we wish you nothing but the best to continue on and enjoy using Ethos and enjoy using it very well in your hands.
Thank you.
So we do have a few.
Ash, teach is an overstretch. Share is probably better.
Share. Okay. We have had some questions come through, which is good.
Okay.
I will start with the first one. Is what do you expect to happen when the blood re-wets a set ethos site? Would ethos still work?
It is fine. It does. So once the ethos is set, it doesn't really re-wet that easily. I mean, you want the blood to go in, and of course, when you close the flap, it is going to get wet and red, and that is fine. But you don't want to, once you've mixed ethos with saline, you don't really want to then re-wet it and then stick some more in. So before you do the ethos, your site has to be relatively dry, like I showed you. And then when you close the flap, of course, it's going to turn red, and it is going to get wet, but it still holds its toughness. And that's why I think overgrafting is not a good idea, because if you have too much, and then you will start shearing it away. Does that make sense?
Yes, I think that has answered the question. The next question is, can ethos be used for vertical augmentation of the posterior mandible?
No. Well, I don't know what can be used for vertical augmentation of the posterior mandible, predictably.
Okay.
I mean, it's not an easy question. Vertical augmentation is a very critical and difficult situation. A lot depends on what's the soft tissue volume, how much vertical augmentation we need. So it's a very different. I suppose you can use ethos, but you'll need some sort of a stabilizer to hold it, and so I don't think it's a very easy solution. You can't, if the question is about whether you can just stick ethos on top and it will grow bone, I wouldn't think it would. Like I said in my end note, ethos is not a miracle material. It is a very good material. It helps you, it makes your job faster, it is predictable, it grows, the turnover is really good. So you do have a significant amount of host bone production, but I don't think we should expect the world out of it beyond what it's designed to do.
Very good answer. I think that is the key thing that people need to take away from you today is ethos is not a miracle product and it
No.
won't graft what we couldn't graft before.
Correct.
Okay, so the next one we have you combined osteodensification with ethos?
I haven't, but if you go to Ethos, if you follow Dominic O'Hooley's work and Peter Fairbairn's work on Facebook, actually, they use this a lot. He does Ethos Case Studies, it's called. I would highly recommend joining Ethos Case Studies on Facebook, and Ash will send you a link. There's a lot of osteodensification with ethos. Anyway, you need a graft, you can use ethos, and osteodensification of versa is basically compacting the bone, and there's no reason why you can't use it with it, especially with sinus lifting and all of that. You can.
Excellent. So just on that, I'll put up a slide at the end of this. And yes, Nick is correct in saying that one of the biggest platforms, which is a worldwide page on Facebook, Ethos Case Studies. It is run by Ethos themselves. It is not an advertising site. It is the good, the bad, and the ugly, peer-to-peer. And it is a wonderful site. So you'll get some really helpful tips and some really interesting cases go up on there. So one word of advice from both myself and Nick would be to jump on that
And
page.
it's a nice group. It's a nice collegiate group. There's people asking questions from all over the world. And I've seen that the answers that people post are quite nice, actually. There's no mudslinging, or there's no ethos is much better than the rest or whatever. It's a very nice peer support group. It's actually a very good support network.
Yeah,
So
it
I
is.
highly recommend joining it.
This one's going to make you use your memory. Case 9, what material did you use to cover the socket of the 2-6 after the extraction and implant placement?
Let's go back. I can't remember the numbering.
And I was like, this one's very specific.
Yeah, but it's good that so my
Kept them awake and they have been listening.
no, I wasn't going to number. Yeah, here. So what was the question?
What material did you use to cover the socket of the 2-6 after exo and implant
Oh,
placement?
this is the 3-6. Case 9 or case 10?
This says case 9.
Oh, so we are looking at the wrong case. Sorry. Here. Okay. Here. Yeah, no, here, because I'd raised a large flap, I gained primary closure on top of it. If you
So
see
that's
the flap,
just the
there is a
ethos.
vertical release incision over there. Then we've got ethos here in the jump space. And then I've closed it completely. There's no healing abutments there. So I've closed that site and we came back, and then, sorry, some of the photos are missing. No, but that's the photo. This photo is taken at stage 2. So there was a additional stage 2 surgery where I placed the healing abutments. And this photo was taken, I think, just before impression.
Excellent.
I haven't put all the photos because then those cases become very long. So I tried to eliminate a few photos,
No, I think they're great. I think people
Yeah.
are just trying to gain as much as they can because they're great. Are you using anesthetic with adrenaline to minimize the bleeding to allow ethos to set better?
I use anesthetic with adrenaline anyways, but not specifically for ethos, but for all surgical work, I always use anesthetic with adrenaline.
Okay. This one is a bit of an open-ended question for you. Any difference in healing/success between immediate and delayed implant / grafting?
I think it's a very site-specific, it's a big topic to talk about. Now, the literature says that type 1 and type 1A uh, immediate implant placements, the success rate is similar. Now, the risks are getting the angulation incorrect, loss of tissue. So that's the problem. So anytime so my default would be to save time. I would say I would attempt placement of an immediate implant. Now, there are times when the site is not actually good. If you're not sure of complete degranulation of the tissue, if there's a periapical infection or whatever, if you have any doubts that there may be some amount of epithelium left in the socket, I would not place that implant. I would go back in after 8 weeks, allow the body nature to take its course, and then place the implant. If I'm very sure that I've degranulated the site very well and I'm not relying on my graft for primary stability of my implant, and then I'm happy to go with immediate implant placement with concomitant grafting on the buccal or additional grafting at the same time.
Thank you. You have so many questions that's come through. It's amazing. I'll shoot a few more at you if you've got 2 more minutes.
Yes.
And then we're going to have to do email responses because you've got a flood of questions, which is phenomenal.
I can talk through. It's not, I'm fine. Yeah, go for it. Yeah.
Okay, so how did you close and routinely close your surgical sites with the immediate molar cases?
Right. A lot of times in that, so I've shown you a few immediate molars, but that's not my go-to. It's not like I do all molars immediate. I pick up immediate molars only in cases where I've got primary stability from the host bone. Now, if you look at the lower molar, let's go back to this case, the last cases. Now, here I considered doing an immediate molar purely because the implant would be positioned sort of at this level in the interradicular bone, and the root has a good amount of divergence. So I'm not, even if in this case, even if we had waited and done a delayed placement, the only thing we would have achieved is a bit of soft tissue closure, right? So implant would still, prosthetically driven implant planning would need the implant to be positioned in the interradicular septum one way or the other. So this is the case I selected for immediate molar. So immediate molar is not my go-to way of doing implants. Now, in this case, we placed a healing abutment, right? So that part is covered. Then ethos was placed, and then I have actually sutured up on top and tried to close it as tightly as possible. Do we have any photos of yeah, sorry. I'll go back to the case, the upper case, where there was an immediate molar. When that was, in this case, we had done complete primary closure. So it depends on every case. Every case is different. I don't always follow a recipe for closure. And there's too many factors depend. Now here I did an immediate molar also because the tooth was not infected. If you go back to the X-ray, if you go back to the PA, the root is fractured. It's non-restorable, but there is no periapic. And of course, I'm not basing my treatment plan just on X-rays. I had taken a scan as well. I didn't bother to put the scan reports in this. So there was no root pathology here. So when you don't have a root pathology in a site like that, plus we've got the septum right up there. So in that case, I knew I was going to do some amount of lifting. So here I thought I would go with an immediate case. On the foreroot, we have root pathology, but I knew, or rather, we can see it on the scan that the apical end of that bone over there is healthy and untouched, so I can anchor the implant in there. And I did the implant placement only if, or rather, I would do the implant placement only if I'm sure that I've taken out all that degranulation. So I would degranulate the site, peep into it, dry that site, make sure you can actually see healthy bone, and then you start doing the implant placement at that stage.
Okay. How do you prevent washout of the graft material ethos when doing a socket graft when you can't get primary closure?
I suppose that's one of the reasons why I don't routinely do socket graft. And you try and close it. The cases that I've done, you don't really fill it too much. You fill it a little bit, so you allow. I mean, you give enough room for soft tissue to grow on it. The idea is to fill the socket in such a way that soft tissue can grow on top of that site rather than overfilling it. And you can take horizontal mattress sutures to evert the soft tissue nice and close to each other. And you can use some oxidized cellulose to just keep it closed. Um,
I guess that rolls into this question as well. If
Blue M gel,
ethos
when it's available, we can probably, it might have some benefit, but I don't think it's sold in Australia yet.
It's sold in Australia, it's sold by Medident, but it's more an oxygen sort of soft tissue healing gel. It's
Mm.
not a gluey sort of gel. So it promotes healing, I believe. I
Yeah.
haven't really had much to do with it. But I believe it's more for the healing side of things.
Yeah.
But that would roll into the question, if ethos cannot be adequately covered by soft tissue, what would you recommend covering the ethos that is exposed to the oral environment? Would you consider a membrane here to cover this or something else?
No, you wouldn't, but you wouldn't do a membrane on top of ethos. So this is a very commonly asked question about ethos and membranes. And there's a specific reason why you cannot use membranes on top of ethos. The way ethos will resorb and the way it works is you have the osteoblastic and osteoclastic activity going in, mainly the osteoblastic activity trying to deposit on and take away ethos. So the chemotactic receptors are looking at ethos as a bony material, they're resorbing it and then depositing new bone or bony substance. Now, you actually want the cells to migrate. So this is very different to what your normal xenograft materials are. With the xenograft, you do not want the cells, the epithelial cells to migrate in very quickly. And that's why bone healing takes longer and epithelium healing is faster. And that's why you want to protect the xenograft with a membrane. So there's a specific reason why we need a membrane in this, in the xenograft. If you place membrane on top of an ethos graft, you will actually not allow the ethos to convert at all. So you'll actually do it more harm than any good. If you have ethos exposed in a site where it's just a socket preservation, it can go either ways. It can sort of get washed out and the soft tissue heals on it. I read somewhere, and Dominic O'Hooley, who's one of the experts in ethos, said that, and even Peter Fairbairn had mentioned this. He said the calcium sulfate part of ethos has some amount of antibacterial effect, and so we see even if it's exposed, it doesn't really get infected. So whereas if you have your xenograft exposed, it will suppurate very, very quickly. You cannot have xenograft exposed to the oral environment. But ethos seems to hold it a little bit better. But these are, I mean, you would leave it exposed, you leave it like this because you couldn't do any better. And that's acceptable in those cases. But as a practice, I wouldn't recommend leaving things open to the oral environment because there's bacteria and all the failures essentially that we have. The reason why we all as dentists have a job is because of bacteria. So as much as it is an antibacterial in the calcium sulfate, I wouldn't want to test it too much.
Excellent. So the next question, I believe, is a yes, but you can answer this how you, I don't know in what regards it's been asked. Can you carve and shape ethos after it's set?
No. So you have to shape it while it's still wet and moist. It's sort of, if you remember dental, if you pour your own models, if you're trying to make a beautiful model, you've done the base pouring and you're using your finger to just clean out the excess and then shaping it to give it a nice shape so that it's nice and smooth. That's the consistency you want to work ethos in. Once it's set, if you try to carve it, it's going to crack off and scoop off. You can't really carve it.
Okay, I will leave you with this as the last question for the evening, and then we will get some more questions over to you. In your videos and routinely, what sutures are you using?
I use nylon 5/0 sutures,
Excellent.
but I think I want to move to the 4/0s. No, sorry, the thinner one, that 6/0.
6/0.
6/0, I think. Yeah, yeah.
6/0 nylon.
6/0 nylon is what I want to move to, but 5/0 seems to do the job. There are times when I feel the 5/0 is a bit too tight. Can I take a minute to go back up to some of the cases, Ash?
Yeah, please.
So I'll show you what it's a good. I was going to bring it up while I was showing it, but I thought I'll show you the problem with nylon 5/0 at times. You just have to wait to get till you get there. Yeah. So if you notice this, and I thought it might heal up, but can you see my cursor, Ash? Can you
Yeah.
see? Yeah. So you see this little indent over there, this cleft? That's actually a line left from the nylon 5/0 suture. This suture was actually quite tight. If you see here, it's almost cutting into it. That's the suture. That's the line that's left. In spite of satisfactory, I mean, it's not a showstopper. It doesn't spoil the case, but you can see that. And this is a low aesthetic zone. It's a lower anterior. But if you leave a cleft, like I mean, it doesn't happen all the time. But I was thinking of moving to a thinner one than nylon. But I like the knot strength of nylon 5/0. And it's quite easy to work with actually. Yeah.
Okay, excellent. Okay, so I will wrap it up for this evening and say a very, very big thank you, Nick, because that was absolutely phenomenal. Amazing cases, great results. And it's always great to hear from you. So Ethos is available from ARC Health in New South Wales and Queensland. It is available from Medident in Melbourne, available from City Dental in Adelaide, available from VP Medical and Dental in Queensland, and available through Southern Implants. So I did say I would share my screen for you to show you this is
Just 1 second, I'll just say thank you to everyone. Can I do that? Or
Of course you can.
yeah, well, guys, thank you so much for attending. It makes all this worth it if you want to come and listen to it. But if you have any questions, feel free to reach out directly to me. You can write an email to the practice or just let Ash know, and I'm very happy to help you with anything. And I do appreciate the time you've taken to spend some time you've taken from your family to spend an hour to hear out all these cases. Thank you very much.
Thank you. So that is can you see my thank you screen, Nick?
Mm-hmm.
So this is the Ethos Case Studies group, and that's exactly how you search it on Facebook. So for everybody that is still on, I appreciate you taking the time to hang on and listen to all the Q&A. That is the Facebook page that we strongly recommend you to go over and have a look at. It is a privately run page, so you just need to be vetted by admin, give them about sort of 12 to 24 hours, and then you'll jump straight in. So once again, I do want to thank everybody. Please feel free to reach out to myself or Nick, and we will get all of the unanswered questions that have come through definitely answered and sent over to everybody. Anything else, please let us know, and have a lovely evening. Thank you so much.